My name's Glenn Whitman, and I have the opportunity to talk to everybody today, probably as in my role as the director of the Cardiac Intensive Care Unit at Johns Hopkins Hospital. Furthermore, I've been on the Critical Care Committee of the STS for the past 10 years and was the chair of the workforce on critical care for the past 6 years. And I think as a result of that, the program committee this year was kind enough to recognize my efforts at improving quality in cardiac care and asked me to talk about the way I round in the era of COVID-19. My philosophy in general for rounding is that it should be multidisciplinary, there should be teaching, we should be involving patients in rounds and patients' families in rounds, and that there be a checklist that's reviewed that makes sure that everybody at the close of rounds knows exactly where we're headed that day with any given patient. The typical rounds have always been the professor, and then the fellow, and then the resident, and the med students, and the nurses, and in the past 10 years, the multidisciplinary aspect about it, so that nutrition, pharmacy, physical therapy, were all present. Well, now we can't do that. You can't have 10 people all together in the same space. So it's made it challenging and inefficient, but that's where we are today. And I think to be socially responsible, we have to separate ourselves. We've decided that you can't just have the nurse at the bedside listening to some voice coming out of a speaker. We need a little bit more of a personal touch than that. And so we have an advanced care practitioner at the bedside with the bedside nurse, and we have a fellow, the cardiac surgery fellow, at the bedside with the advanced care practitioner and the bedside nurse. And then remotely are going to be the dietitian, the nutritionist, the pharmacist, and in a room will be me with those unlucky enough to be in the same space as me because they're targets for me asking them questions, will be a PGY2 and a med student and any other learners. And the people in that room, generally there's no more than 4 in that room, and we socially distance, and there's 3 on rounds. It's a total of 7 people, plus nutrition and pharmacy remote, and that's how we have the 9 or 10 people still on rounds. We also have this high fidelity capability now for video, and so we have an iPad that's looking right at the patient that we can turn on and off. We try to maintain HIPAA compliance, but the patients love listening to the voice coming out of the iPad, looking into the iPad, and recognizing that there are a lot of people caring for them. We've had some problems with ambient noise in terms of being able to just speak to the people at the table without all the other influences around in the hallway. But I think we've gotten around that, and I think you'll see that on the video, that we really can focus on talking to each other with this equipment that is available to all of us. We all have different thresholds for being frustrated, and I think what's happened on rounds is that sometimes the equipment doesn't always work right, and you have to have the patience to stop and get it all working. Because it's possible, even with the equipment not working, to get rounds over with. Not everybody will participate, not everybody will be taught, but you get the job done from a patient's point of view. On the other hand, if the role of rounds is not only to care for patients but to teach and to make sure that everybody knows what's going on, in this new era, when something stops working or the Bluetooth connection all of a sudden disappears and you have to reconnect, and someone from remotely has to say, "Stop, I can't hear," everything comes to a halt, something that never happened before. And various members of the team can either feel like or actually roll their eyes and say, oh my gosh, how long can this take? This has nothing to do with rounds. I can't stand this anymore. It requires the team and the leader to continue to impress upon everybody that this isn't normal, although it may be the new normal, but it isn't normal, and we just have to be patient and make this work. And rounds take longer, and they're a little clunkier, unfortunately. Hey Trish, can you hear me?
Yes, I can.
Say yes, I can.
Yep, I can.
Yes, we can.
It's hard to hear you though. Why are you not coming through the speaker?
Stephanie, can you hear me?
Now it's better. Okay.
Yeah, I can hear everybody.
All right, everybody okay?
If you want to join.
I'm okay. Steph's okay.
All right.
Okay, we're getting the family on the phone.
Okay, Sharon is on. Let me put her on speaker.
This has been the spectacular benefit of COVID-19. I never made rounds with a family before. If they were in the room, absolutely, because I'd go into a room and they'd be listening to rounds. But if they were remote, they were never involved. And by the way, as a result of the influence of Alden Harkin, who some of you all may know, who's a cardiac surgeon and had been chair at Colorado and then in Oakland, San Francisco, what he did was always call families once or twice a day, depending upon how sick their family members were, to keep them up to date about what was going on. And as a result of training with him, I've always done the same. But what COVID-19 has done is it has taught us that you can, on cell phone or on Zoom, you can include families depending upon how sophisticated they are. But it's incredible. Everybody has a cell phone now. So everybody can be on a cell phone listening to rounds. And you can FaceTime, and if they have the ability, you can bring them in on Zoom. And you can even do that in a HIPAA-compliant way. And so patients' families are on rounds for every patient in a way that's never been done before. Family, do you have any questions?
Just wondering for today, it sounds like we're trying to move the ECMO off by tomorrow or sometime in the next couple of days.
That's exactly right.
I'm just interested in when would be good times to check in on his progress with that.
How about if I call you this evening? I'll call you this evening and give you an update on how we did with all of these changes. How's that?
Yes, that'd be great. Thank you.
All right, and you're talking to Glenn Whitman, by the way. Okay, I'm a member of the team. We don't touch our patients the way we used to. I think one of the tenets of care is that patients not only see you, but they feel you. I am not a great believer in what I learn when I listen to a person's breath sounds. I mean, I believe in chest x-rays and CT scans, embarrassingly, but there's no question when I listen to a patient's lungs, I do learn something, but the patient feels cared for. Or when we're making rounds and I've got my hand on their foot or their knee while we're making rounds. I think patients really appreciate that. I know I did when I was a patient. And that is now gone. And hopefully it'll be able to come back. I want this to be as beneficial and as productive and educational for them as I possibly can. And I try not to let anybody feel used or abused. I want everybody to feel like he or she's a valuable participant and try to give everybody a voice in rounds. I feel as if when I have everybody in front of me so I can look people in the eye, I can make sure that no one's drifting off, that everybody's paying attention, and I intersperse rounds with questions to everybody to make sure they know that I want them paying attention, listening to all the things that are going on so that they learn as much as possible from each patient. And for whatever reason, knowing that they're available to be questioned keeps them involved. Now it's a little harder because I can't see them. Sometimes they can't see me, and they may not be as focused as I want them to be. So that makes it harder. On the other hand, I do try to ask everybody questions while we're rounding, make sure they know that they're at risk for paying attention or being called out.
Did you see the chest X-ray?
Yeah, hey, Darshan, that's not left lower lobe consolidation, that's left lower lobe atelectasis.
Okay.
98% of our patients have left lower lobe atelectasis, and they silhouette out their left hemidiaphragm post-op. It's not a consolidated left lung, lower lobe, it's just atelectatic. Well, let's discuss the anticoagulation. That normally doesn't start until the 24th hour, and sometimes the 48th. So we'll discuss that with Dan tomorrow, okay? Darshan, 74049.
So he's 740, 49. So he's up 9. He should be down 8. Or up 10, down 8. Up 10, down 8. So we'll just say it should be down 8 roughly. So it should be 32. You said it's 40. That's a difference of 8. So 8 times 2/3 is 5. So the difference is 5. He should be up 5.
He's got a base.
Base excess of 5.
Perfect. So he's got a metabolic alkalosis already.
Yep.
Well, that's fantastic. Keep going.
0.6, his CI is 4.2, and his power is 4.6.
First of all, Joanna, I love the fact that you're speaking right into that speaker because we can hear you loudly and clearly.
Okay, good.
Secondly, that's great. Tell me about his RVAD.
Yeah, so RVAD, his
The items on those checklists are, in general, the result of errors that we've made that are avoidable. And let me give you an example. Addressing whether a central line is needed. That's on our checklist. Did we address it? Addressing whether a person needs a Foley. We address what labs do we want tonight? Are we overdoing it? Are we underdoing it? Does a person need a chest X-ray tomorrow? We address those issues. We also address issues of routine care. If they're on a ventilator, is the head of the bed up 30 degrees? Are you brushing their teeth? Are you doing the VAP bundle? As an example, it's on rounds, on the checklist, to make sure we address those issues. The nurses have they've always been great. Nurses have always been kinder to the patients than any doctor I've ever met, but they have really been great, and they've been going the extra mile to make sure families are included and patients feel loved. I think the silver lining in this crisis is hard to see. I don't like it, but you heard some of the things that I think have been silver linings. But I think all in all, I hope we get back to the way we were while incorporating families on rounds and incorporating the high-tech stuff that we've learned, so that people who can't be on rounds, wherever they are, can be part of rounds. It's so inefficient, I think, for various people on rounds to be listening to so much of rounds where they really don't have that much of a role, and being able to be remote, let's pretend pharmacy, or let's pretend nutrition or physical therapy. They can be present, but they can be in different spaces, and they can be working, and listening to the parts of rounds that are meaningful for them. Harder to do when you're all part of a group walking around for 3 hours. So there may be a silver lining. I want to thank the STS for giving me the privilege to share with everybody the way we round in the cardiac ICU at Johns Hopkins. I hope there's some aspects of it that you can take away that may improve the way you round. I'm sure you do other things that I wish I could see that would improve the way we round. But regardless, thank you very much, STS, and I hope this is an enjoyable session for you.